The purpose of this lecture is to provide you with an overview of the history of public health in the West so that you can better understand its role in the prevention of infectious disease. We begin with a rather ambitious definition of public health from Charles Edward Winslow, who in 1920 was a professor of public health at Yale University. Winslow defined public health as, quote, the science and art of preventing disease, prolonging life, and promoting physical health and efficiency through organized community efforts and for the sanitation of the environment, the control of community infections, the education of the individual in principles of personal hygiene, the organization of medical and nursing service for the early diagnosis and preventive treatment of disease, and the development of the social machinery which will ensure every individual in the community a standard of living adequate for the maintenance of health. As I said previously, it is an ambitious definition, but it also stands to provide a good indicator of the scope that public health professionals envisioned modern public health taking. If we were to consider it against the backdrop of modern public health today, the only thing missing is perhaps the inclusion of mental health. So from that point, the first things that we have to do to kind of understand this role of public health is first off understand and get this historical perspective of how people perceive disease historically. And again, being an overview lecture, I'm not going to go into great detail on some of the classical understandings of disease, but I think it's important to know these because these principles were pretty much in play from 4th century BCE all the way into the 19th century. So the early concepts of disease. Essentially, this is where we talk about mythology, superstition, and religion. This notion of the Greek, the Pandora's box, that Zeus had stuffed all of the ills and diseases in the world into this box and gave it to Mercury. Mercury got tired, so he handed it off to Epimetheus, and his wife got curious and opened it up and unleashed all of this misery into the world. The reason why I bring this up is because, aside from the fact that it has absolutely no scientific bearing at all, is that it hints at this sense of fatalism, the sense of unpredictability that humans have had in their relationship with disease. Because really, once we start looking at this in the longue durée, this long scope, it takes a long time for people to finally latch on to something that makes sense. The dominant explanation for disease was defined by Hippocrates, the father of Western medicine. And Hippocrates, he couched disease in the concept of humorism. Disease, and if we think about disease in this way, it's dis-ease, this discomfort, was a result of an imbalance in the four humors. And if you look at the photograph of the engraving there on the slide, these humors are melancholy, bile, phlegm, blood, and each one of them corresponded with one of the seasons. They also corresponded with the core elements, earth, wind, fire, water. And the sense was that people were ill when they had an imbalance to the humor. You had too much phlegm, you have too much bile. And those coordinated also with certain parts of the body as well. And the trick behind medicine was that medicine restored balance. And that could be through diet, lifestyle changes, more sleep, less sleep, drugs, and or therapies. And this is where, we get to a lot of this, what we call heroic medicine, where it depended heavily upon bloodletting and purgatives, the sense that you had too much of one of these humors, so it made sense to let one go. And again, this will dominate medical thought for many, many centuries in some shape or form. And then part and parcel to it was the notion of miasmas. So on one point, your body had, you were sick because you had an imbalance of your humors. But at the same time, people could readily observe that a sick person is in the house and other people in the house end up with the same illness. So there was this sense of you can also become sick from exposure to something that's making others sick. And the way that Hippocrates explained this was through this notion of bad air, um, foul air. And this is where we get these miasmas. And it's the sense that, um, you know, dirt, something in the natural order or in the, something physical, it can also make you sick. And the way that the humors played into that was that when your humors were out of line, it could make you more susceptible to these diseases of bad air. So, and they played around with this idea of of person to person contagion. It wasn't totally out of the picture, um, but the mechanisms were what was missing. People would understand, if someone's sick, you can get sick too. They just didn't fully understand the science behind contagion, what it was about that sick person, what kind of exposure, what kind of contact would spread disease. And we really see this come to bear in this period at the early modern age, from the 14th, which would be the 1300s, through the 1600s, and this is when the bubonic plague raged across Europe. And conservatively, the bubonic plague wiped out in the Black Death. This was one that this kind of inaugural epidemic, and these were truly pandemics actually, of bubonic plague. The Black Death was in the 14th, 15th centuries, and this was the one in the 14th century was the one that wiped out almost a quarter of the population of Europe. In some places, some towns, the mortality rate was like 90%. We talk about historical implications of disease. This changed the face of Europe. It changed relationships. It had economic, intellectual, artistic, religious. The ramifications of this mass casualty event were such that it transformed European culture. This is what led to the Renaissance. This is what shook the power of the church. This is what gave power to the agrarian laborers in Western Europe and ended the feudal system. And it was largely something that was incomprehensible. Um, the bubonic plague is caused by the Yersinia bacillus. It's a infection that fleas carry, and it infects the flea. The flea it's a bloodborne exposure, and ironically, it can be killed with soap and water. But when you have people living in close proximity to each other, and these new urban areas, there's very little that you can do. So people understood it as something caused by the long-term standing of miasmas, the bad air, something the weather changed, something was out of sync in this world, and then direct contact. You wanted to avoid contact with those who had the bubonic plague, and what happens with the plague itself is it undergoes evolution as diseases do, and it went from being direct contact to a pneumonic, a respiratory based infection, which was truly out of control. And the traditional treatments, nothing worked, because any sort of management of a high fever during this time period, there were no intravenous fluids. Oftentimes, the treatment was counterproductive to what we would think of today with providing intravenous fluids, with purgatives to cause somebody to expel, or bloodletting. These are things that you wouldn't do for a fever. So without effective treatments, the reliance was on preventing it. They knew that it happened when people entered the community who were sick. So quarantine had been used since the classical times. Keep the sick people away, and that ice, in quarantine is based on the Latin, 40 days, which is rather an extensive quarantine. But the quarantine also in our modern concept and understanding of quarantine is what you do if somebody's exposed to a disease. You don't want them to then spread it. So you have to make sure they don't have it, or if they do have it, you want them to recover because you don't want an accidental exposure. So quarantine means that's how we handle somebody who's been exposed to disease, possibly. And then if somebody is infected, we use isolation, which prevents them from interacting with others and getting others sick. So the sense of, understanding how you got sick, why you got sick, basic ideas were present. I mean, it wasn't that, people did not understand that one person could get another person sick. And again, we stress this, it's the mechanism. They did not understand what exactly was making a person sick, why some people got sick and some people didn't. So these ideas, the more modern ideas about disease and what makes people sick, start to evolve really in the 16th century with a couple of, and I'm just going to go through a few key thinkers here. The first one of note is an Italian by the name of Girolamo Fracastoro, and he was active in the 1540s. In 1546, he wrote a piece on, and again, apologize for my horrible Italian, De Contagione and Contagiosus Morbus, on contagion and disease contagion. Basically, and this is what's really important about this, Fracastoro argued that disease is caused by by a seed, that there is a seed that causes disease to spread, and that these seeds can be transmitted by direct contact, the air, or contaminated clothing or linens. One of the things that many of these early innovative thinkers on disease were having to get around, this big stumbling point that they were maneuvering around, was this notion that of spontaneous generation, that disease could just appear anywhere. And the trick was, how do you explain what causes disease? Because oftentimes you cannot see it. And so Fracastoro is really important here, because he starts imagining it as seeds, comparable to a very small mustard seed that you cannot see. And that plants can spread seeds. If the wind is blowing, if it's on your clothing, that he's making those connections. That there's something extremely small that we're not able to see, and that is what spreads disease. And again, that's getting around this idea of spontaneous generation, which, the notion of how can you isolate something to be sure that it's not contaminated. And because for most part, if you've left something and it molded, or if it's the old standard was, are the maggots in the meat, and they just, when you let meat rot, do the maggots magically appear, or is something leaving is there that connection? And the spontaneous generation, again, that's going to be something that it's going to take Pasteur in the 19th century to finally close the book on the idea. We also, in the 17th century, with Leeuwenhoek, have the development of microscopy and the study of microbes. In the 1670s, he's able to see bacteria through his microscopes. And so he starts unveiling this other world, this tiny world. And again, as that connects to these notions of these seeds, this idea that there's something, an actual living creature, albeit very small, that is the source of disease. I mean, these ideas start to come together. But for the most part, I mean, the dominant theme remains miasmas. Humoral medicine starts to decline in the 18th century, but it's still these are the practices that have really become entrenched. But there is this kind of these studies that are beginning to poke inside in terms of this other microscopic level. Now, important for the study in public health is a fellow by the name of John Pringle in the 1740s. He was a Scottish military surgeon to the British Army during the Wars of Succession. And he had been the physician to the Duke of Cumberland, and he was also the chief physician to George III. He wrote a piece called Observations on the Diseases of the Army in 1752, and he proposed measures that would improve the health of soldiers, because an army was only as strong as its weakest soldier. And armies, also oftentimes were kind of roving troops of infection. They, a lot of disease. The cleanliness was always an issue. There was a lot of communicable diseases in the military, and as a military surgeon, he saw from the ground up in terms of what kinds of problems existed, and one of these significant ones had to do with what was called jail fever. And it's called jail fever because it oftentimes emerged in prisons, asylums, hospitals. And jail fever was typhus. Typhus is an infection carried by lice. And one of his major points was that you have to do something about the living conditions to improve health, improve ventilation, improve latrine design, make sure that they're not constantly reinfecting themselves and each other. And this importance of hygiene that Pringle advances in the 18th century, really, this is innovative. This notion that if you create an environment that is less conducive to filth, and it tied in line with miasma, the theory of miasmas, this bad air, it would be a healthier environment. People were not clean. Bathing was oftentimes, concerned as that was something that if you did it too much, and this aligned with religious thought at the time, that you were obviously doing something strange in the bathtub. But this notion that it was the body's defenses, our natural defenses against disease were carried in some of the dirt that we always had on us. And if you bathed too much, you would be stripping the body of one of its layers of defense. Also, in the absence of readily available warm water, and running water for that part, most people, they bathed in a superficial way where, your hands, your face, but the full body immersion kind of bathing that we do every day was not common unless you were in the upper classes. And that could be dictated, culturally. So this notion of personal hygiene, and he made this connection as typhus, jail fever, was associated with filth. And we know that as it being borne by, a louse-borne disease, yes. And that if you cleaned the filth, if you removed the filth, you could also remove the potential for disease. So that was the 1740s. Another kind of contemporary to Pringle was James Lynn. And James Lynn was a naval surgeon, also of Scottish descent. And he had been, as a naval surgeon, and again, shipboard and monitoring groups of sailors in close quarters. Um, one of the problems the British Navy had was with scurvy. Scurvy is a severe vitamin C deficiency that once you get scurvy, it then manifests almost as an autoimmune disease and causes a rapid degeneration of the nervous and immune system and has cardiovascular implications. It's a really terrible disease, and it is a vitamin C deficiency. If you're living on a ship, your access to fresh fruits and vegetables and things is going to be very limited because you're on a ship in the middle of the ocean. And that's why this problem was so widespread amongst sailors, because their diet was very limited. And Lynn's kind of claim to fame is that in 1754 he started this one of our first clinical trials in the scientific sense, where he took, based on kind of some anecdotal evidence that he'd gathered over the years, he took 12 sailors and he divided them into 6 pairs, and he gave each pair a different treatment for scurvy. That he had, and one of the easiest ways to replenish vitamin C is, of course, via citrus fruits. And in his study, he clearly showed that the sailors who were given citrus, limes, they recovered and did quite well. The others did not. And so he has kind of definitive, he has a definitive example of what's work, what will work in terms of reversing scurvy, and the evidence to back it up. That it's, and this is important because if you're going to propose a new way of doing something, you have to have rational reason supported by evidence. And his extensive research on scurvy and its solution basically led to the change in the British Navy's dietary regimen 50 years later. That being the clincher, that it took after his lifetime to get this actually put into the rules of the Navy. But it was allowed him, this study that he did is the backing, and it was based on anecdotal evidence, and then he tried it out, recorded his findings, and yes, if you give people citrus, and it can reverse scurvy, and it can also prevent it. And this is why the British Army will, the British Navy will carry, a significant portion of a ration of limes with them. Now, it's also important with Lynn, and this is kind of one of those key ideas that you need to write down and put a star by it. Lynn did not understand what caused scurvy. He didn't understand the mechanism, but he was able to prevent it. He actually thought scurvy was caused by sea air trapping toxins in the body. In reality, it is that vitamin C deficiency that breaks down the connective tissue and creates serious abnormality in the capillaries and other autoimmune effects. But Lynn did not understand that. But through his work and his clinical study, even without understanding what really caused scurvy, he was able to prevent it. He was able to treat it in many cases because and these were based on anecdotal things he had heard. He said people had said if those that eat citrus and they don't have this problem. There are people and this testing out of what he had heard creates a preventive strategy. And that's important for public health because in many cases, you can get to prevention without fully understanding the mechanism of the disease. And that's a little hard to wrap our modern minds around, but it is really key. Now, there were others, and especially starting in the 19th century, um, who began to challenge the status quo, this older, Hippocratic, humoral-based medicine. And this shows up in a couple of cases I've got here. Francois Broussais and Pierre Louis, these were two French doctors in 1832. And what Pierre Louis did was, Broussais at the time was a very well-respected doctor. And this was during the first major wave of cholera that came through Europe in the 1832. And one of the strategies of dealing with a disease manifestation that included fever and in cholera's case, gastrointestinal distress, was bloodletting. The sense that you have to, reduce the sanguinity of the body, and that would help to restore that humoral balance. Pierre Louis, was adamant that this did not work, and because he was looking at the numbers of patients who had been treated like this and that had died, and the statistical comparisons, and Louis' challenge to Broussais, the more established doctor, was that bloodletting is not helping and is probably contributing to the overall mortality. So it's something that's not just not helping, it's also and going to kill patients as well. Those that are in weakened condition, you also then add this to it, and you as a doctor are increasing the mortality rate. Of course, Pierre Louis is right. However, Broussais, the more established doctor, and this also happens with Benjamin Rush in the Philadelphia yellow fever epidemic, a very similar kind of approach. This unwillingness to step away from this particular therapeutic. Broussais, dismisses Pierre Louis, and is unwilling to consider that the doctor's treatments, the therapeutics, are contributing to the mortality rate. And people, I've always asked, well, why would somebody submit to bloodletting? Why would somebody take these horrible purgatives? This is what they expected medicine to do. I mean, this sense that medicine, did something. It made you sick, or then you threw up, or this is what would help you get better. And so this expectation that you called the doctor in, and the doctor was going to do something, and this heroic medicine, as they called it, which was bloodletting and the purgatives, this was very invasive. You would know that you've been to the doctor because this was the effect. And so it's hard for people to let this go because it's been used for so long. And this is when you challenge some of these preconceived notions, but also when you challenge that the doctor's not helping. Because one of the core things in the Hippocratic Oath, going all the way back, is you do no harm, that you're not, the physician is there to protect life. And the thought that the doctor was contributing to suffering and mortality, doing a kind of this time-honored traditional medicine, it was hard for people to grasp. Another a similar kind of controversy is with Ignaz Semmelweis, who in the 1840s, he was working in the Vienna Hospital. And Vienna Hospital was a teaching hospital. It had medical students there. Had a very robust gross anatomy program where students did dissections all morning, and this close relation. You have to understand human anatomy before you can understand medical treatment. And one of the things that Semmelweis had noticed was they had their wards divided there, their maternity wards, was that the ward where the women were attended to by midwives, by you know, these supplementary practitioners, the kind of traditional uh, assistant that helped with childbirth, were the midwives assisted the births. There was very, very few cases of puerperal fever or septic shock following birth. I mean, this was a deadly condition. However, where the young doctors were attending the women who gave birth, there was this phenomenal increase in the number of patients who died from sepsis, from these secondary infections. And Semmelweis was trying to figure out, why was this? Why was the midwife, who was viewed as a lesser kind of, this, in the gender, the sexism, and this viewing of a midwife as something archaic, superstitious, untrained, unable to understand the finer points of obstetrics. Why did women who saw the midwives not have the same occurrence and the same mortality rate from puerperal fever? And so he started kind of putting it together, and what was it that the male medical students were doing that was different? Well, he sorted it out, and he realized that the male students were attending the dissections in the morning and then going straight to the deliveries. And they weren't thoroughly washing their hands, so they were touching morbid flesh, dead bodies, and then going and delivering a baby, which was exposing women to this streptococcal infection, which causes the septic shock. And one of the ways that he sorted this out, in kind of another conclusive layer of evidence, was that one of his peers during a dissection had sliced his hand. And the disease that manifested in him had many of the same symptoms and hallmarks of puerperal fever that they saw in women. And this realization of, this is the same disease, this is the same ailment, and the common denominator to it was the dissection room. And so Semmelweis starts demanding that students wash their hands as a means for preventing the spread of disease. And again, this runs into a brick wall for the most part, because students don't want to be told that you're spreading disease, and nor do they want to think that what they're doing is wrong. Also, Semmelweis, his personality got in the way. He didn't just ask, and there's one, to change people's minds about a practice. You can't just call them idiots and tell them that you're murdering women. That kind of went over poorly. So that gets him painted as a radical. He gets in fights with his superiors. He's ultimately dismissed at some point. And his is a very sad story too, because he had latched on to this notion of the strict hand washing, and I'm not saying that people went from the anatomy lab with blood and guts dripping from their hands and then proceeded to deliver a baby, but there was just a cursory of wiping off your hands and then going into the delivery room. Semmelweis was arguing that you scrub your hands, you wash your hands thoroughly, you separate the two areas completely. You don't wipe your hands on your coat, and but he did not share this information in a way that made people want to change what they were doing. Um, and the fact that he ran afoul with the medical school's authorities, and he also didn't publish his findings. And when he did, he published them in Hungarian, which nobody reads Hungarian at this time aside from Hungarians. I mean, if you were publishing anything academic during the 19th century, you had, if it was medicine, you published it in French or English or German later in the century. That was it. You didn't publish it in Hungarian any more than you would publish it in Finnish, because it would have just such a limited audience. And so he kind of ends up on the dust heap of history in the sense that he didn't put his ideas out there in such a way. And, his personality was one that, he was that guy. He was right, but he was also really, put it mildly, he was a bit of an ass. Now, at the same time, in the United States, Oliver Wendell Holmes, kind of one of the celebrated doctors, he was highly respected. And he was a professor at Harvard Medical School and Dartmouth Medical School, part of the Massachusetts General Hospital. He was also thinking along the same lines as Semmelweis, but this again is a different personality. And he writes and publishes a paper on the contagiousness of puerperal fever in 1843. So he gets his ideas out there. Now, and he's advocating similar reforms, hand washing, this if students are because this movement between the anatomy lab and the labor and delivery room, they're seeing that connection. And Oliver Wendell Holmes, he's advocating for reforms in hospital design, ventilation, hand washing amongst doctors and nurses, and he's also challenged on it. And one of his colleagues, and again, people don't like this unwillingness to change because, one, you don't want to think that you're doing anything to hurt your patient, but the other part is like, we've always done it this way. Not everybody, not everybody's died. And so his, kind of adversary in this was one of his peers, Dr. Charles Meigs, who was a very well-respected obstetrician. And Meigs basically said, I don't know what causes puerperal fever, but I know it's not me. It's either an accident or the will of God, but it's not me. I'm not part of the contagion, the infection chain. And we look back at that and we think, well, it's very an ignorant stance to take. But again, Meigs was kind of refusing to wrap his head around this new idea that yes, you are playing part in the spread of this very horrible, very miserably painful. I mean, this did not. If you had puerperal fever, you did not recover. It was the leading cause of maternal mortality during this time period. And to think that the doctor, a very good doctor, could have something to do with this, it was just difficult to take. So those are the ideas kind of going into how medicine was viewing disease, and in this Western medicine, there's kind of some of these general ideas on where we were with hand washing, contagion, and we're going to swing back around to public health in the sense that, and this notion of, we're going to kind of come back around to this idea of, okay, well, this is what the medical thought was. Now, how did it relate to public health? And that's where we'll begin the second part on the sanitary idea. So, this notion that public health serves to protect the health of the people, all of the people. This is more than, medicine is the health of the patient, a one-to-one transaction. Public health is the health of the population. And this notion, this relationship between public health as an extension of the government, as an extension of the the responsibilities as part of that kind of that, you know, John Locke's social contract, social contract, that this is part of what the government owes its subjects. This is a new idea, and it emerges in the 18th century. The sense that the state is to play a role in the protection of its people. Now, a lot of this also has to do with the fact that over the 18th and 19th century, we've developed into more urban populations. Cities have grown larger, and therefore the potential for urban problems has also grown with it. When people live in close quarters, there is more exposure to filth, to where does the water come from? This closer quarters. Now, it's also through the rationalist movement and through people such as utilitarians, Jeremy Bentham's groups, this notion that the good the good to the most people is kind of what the state needs to do. What benefits people the most, and how can you do the most good for the most people? And so this combined with this kind of these economic notions, we're entering into this 19th century, beginnings of the Industrial Revolution, more of this capitalist principle. The health of your population is also going to impact your economy. And this interest in keeping your working population healthy and efficient is really starts to emerge, especially in England and in France. This will lead, if you're concerned about your population, it will require kind of a better understanding of that population. Now, in 1662, in England, John Gaunt had developed what are called the Bills of Mortality. And these are largely just this record of what are people dying from? Where do they live? Who were they? What did they die from? Now, granted, the church and the Catholic Church, typically, or the Church of England, kept those records, but those were religious records. What John Gaunt does is kind of add some standardization to them. It's a matter of who were they, how old were they, what did they die from, when did they die, some very basic information so that you're getting an idea. And it's also some standardized nomenclature too. This is why you can see if you've got 1,000 people who died from plague last week, that's an indication there might be a problem with plague. And in England, and this would be for England and Wales, kind of building on this idea and this need for identifying and who are your subjects, who is the population. You have the expansion of the General Registrar's Office in 1837 with William Farr, who's an English physician and economist who was trained in France, because the French are really taking the lead in statistics at this time. And he sets up the General Registrar's Office. And basically it's monitoring births, deaths, marriages. And it's recording the information very systematically so that it's accessible and that you can start looking at it in terms of over multiple years and putting it into different areas. And so it's very useful statistics. Now, statistics are key for disease surveillance. This important ability to be able to say, you've got so many people who every July die from typhoid in this area. Maybe there's something that's happening in July in this area. The French really took the lead in this. And for population statistics, Louis René Villermé in 1830s, he was a physician and he was an economist. So this connection between the economy and the health of the population. Villermé, his primary studies were on cholera because this was the pandemic of the 1830s, he starts looking at, and I've got a map of Paris here, and these areas that are marked with Roman numerals, these are the arrondissements. These are the districts of Paris. And he was wondering, why was it that in some districts more people died? So what was it? And he starts looking at, did they, was how far away from the river were these areas? What was their elevation? How much sunlight did they receive? What kind of streets did they have? And he can't find anything that really explains, a similarity between two areas, two arrondissements with very high death rates. And then he pulls up tax rates, which tax rates provided a look into the wealth of a district, of an arrondissement. And bingo, the mortality rates corresponded with the tax rates. The poorer the people were, the higher the mortality. And, again, this is something we kind of take as, oh, well, bingo, yeah, that makes sense. But for this time period, no. This was the sense that, well, people had always, there were always poor people. But this notion that in the cities, poverty became a real marker of poor health. And Villermé, this is the socioeconomic factors of health. The poorer areas, it's malnutrition, it's susceptibility to disease. It's also the quality of the dwellings. Do they have access to clean water? What is the drainage and the sewage conditions? And this is where you start seeing this tie-in to what can the government do to help the people, and this notion that public health and reform go hand in hand. So going back to England, in 1842, Sir Edwin Chadwick had been commissioned to write a study following an outbreak of typhoid in London, and to figure out what it was that contributed to the mortality rate. His report on the sanitary conditions of the laboring population of Great Britain, again, is doing what Villermé did. It's tying those socioeconomic conditions to health. And he's arguing that if you put the money, the government was to put the money into civil engineering to improve drainage, water supply, and sewage, it would be a game changer. You would drastically reduce the mortality rate, and in the long run, it would cost the government less. You would have a healthier, more efficient laboring class, and that would be good for the health of the whole city. His results are, these become instances where he helps organize groups to take this on, presents ideas to Parliament. Some of these include the Nuisance Removal Act of 1846, which basically says the government can fine landlords and property owners for for failure to provide decent drainage and water supply. The Public Health Act of 1848, which allows for the establishment of public health boards, the cities, to ensure clean water. These were all recommendations in the Public Health Act of 1848. It takes the second Public Health Act of 1875 to make them requirements, make them mandatory requirements on local governments. But the idea there is that the government has a role to play at the local and the national level. And he also, founds the Epidemiological Society of London. That's going to be important because epidemiology is the statistical arm of disease surveillance. This is the big one. This is where you look and see the trends. And the father of epidemiology, pretty much, is an Englishman, a doctor by the name of John Snow. And and as you've read Snow's paper, so I'm going to kind of not go into too much incredible detail about this, but John Snow, when cholera arrived, he's going to be focused on cholera. And when cholera arrived in the 1830s with the first global pandemic, this was a scary disease. They had not seen it outside of the South Asia, and a person could be up walking around one point, and then the end of the day they could be dead. In the 1830s, the 1831-1832 outbreak in London killed 21,000 people, and these were significant outbreaks, and they kept returning. And 1832, 1848, 1853, 1865 in London. It was kind of like one of the last ones. But Snow, his original specialty was anesthesiology. He had been the one to administer chloroform to Queen Victoria during childbirth. But as he was a general practitioner, he'd also had a lot of contact with cholera patients. And one of the things that he sorted out right away was that cholera was a gastrointestinal disease. And that's where he knew that it wasn't a respiratory disorder. And, I mean, because cholera gets kind of confusing towards the end of life, because the human body, as it breaks down and as the person dies from cholera, there are many symptoms going on there. But Snow knew that it's primarily manifesting as a gastrointestinal disorder. And those symptoms always pointed to either food or water as primary source. And Snow in 1849, became rather convinced that it was water. Now, he was basing his convictions on the fact that it was observations, kind of anecdotal observations. But this was important because it's narrowing it down, because a lot of the others were saying, well, it's miasma, it's bad air. But Snow was noticing it's concentrated in particular areas. Some areas would be hard hit by cholera, some wouldn't be. And poverty did play into it. So he starts looking at water and food. And water is kind of the easy one to look at because not everybody's eating the same thing. Water, however, was supplied by a couple of companies. The wealthier parts of London had their own wells, and these were deeper water wells. These other parts depended on either shallower wells or cisterns that were filled with water, and this is where the contamination came from. So in these neighborhood outbreaks, this common denominator that he's noticing is the water supply. And he sees it as soon as 1849, but it's not really until the 1853 outbreak in August that he's able to walk through it and start making some careful observations that narrows it down to two specific water companies, and the fact that in the Soho district of London that was so hard hit, everybody who contracted cholera was a recipient or somehow related to receiving water at this one particular pump, which was the Broad Street pump. And the easiest way to halt the epidemic was to take the handle off the pump and shut it down. And what he did, though, and this is what makes Snow considered the father of epidemiology, this was boots on the ground kind of research. He got a map, and he went basically through his investigations. This was contact tracing. Where were all the cases located? And so he started making those marks on his map. Where do they receive their water? And then how do you account for the outliers? Because there's an outlier. There's this one brewery that the men there, they never got sick. Well, he finds out going to the brewery, well, they didn't drink the water, they drank beer. And they also had a well. There's also a workhouse in the area, and the workhouse is full of poor people in miserable health conditions. They never got sick. Well, I think one or two of them did. Why not? They had their own well. And then how do you account for some of the outliers? And so he had to go and kind of trace down to, well, some of the outliers in the outbreak who were not concentrated in this close proximity to the pump. Well, they actually also did have a connection to the pump where they were getting their water, brought in from quite some distance because they liked it better. And ultimately, what they find out is with this one pump is there is seepage from a cesspit where people, put a sewer into the pump with water. I mean, it's basically, and cholera is present in feces, and it was from an infected person because the cholera bacillus is present in the feces of somebody who's sick. So that's where you get some of the direct person to person spread of the disease, and that was that continual propagation, that continual source of infection was the seepage from that cesspit into the water supply. And as the cesspit filled with more excrement that was infected with the cholera bacillus, then more people got sick. But it took more than just the hunch. It's one thing to say, well, I think it's water. He had to have proof to have action. And the proof was in, drawing out was later people call the ghost map, marking out where the deaths occurred and what was their source of water supply, and then accounting for the outliers. Why didn't this group of people, why didn't this person, or why did this person over here get it? And that's where it's really important in terms of the history of epidemiology. Now, for epidemiology, here's its modern definition. It's the study of the distribution and determinants of health-related states or events in specific populations and the application of the study to the control of health problems. Basically, you look at where, who's getting sick, where they're getting sick, when they're getting sick, and then what factors are present. So you're finding the patterns and then making sure that the pattern can be explained by what the evidence that you're seeing. So it's not just correlation. I mean, it's something that can be explained by the science present. So epidemiology is that investigative piece, and much of it's done through statistics, but you have to start with the numbers. And this is where it's, public health is a medicine on a very broad scale. The bacillus, the cholera bacillus, wouldn't be seen until Robert Koch in the 1880s. But that didn't matter. John Snow had an idea of where, what all these people who were sick have in common. And if it's water, then shut down the water. And that's how you stop it. So this, again, we're back to this notion of you don't have to understand it 100% to be able to resolve the issue. Now, getting back to understandings of disease, we're finally at a point in history where we're going to embrace or discover our more modern understanding. Miasma, however, I'm going to point out that most all of the public health authorities clung to the theory of miasma, and it was okay. I mean, granted, it was wrong, but it was okay because even though Snow takes his findings, to a commission that Parliament had appointed, and really argues in terms of water and there's something in the water, that sort of thing. It's still, it's not widely accepted. It's like, okay, the fix was the fact that you shut down this pump, but the notion was that somehow bad air was connected to the water. The sense of bad air and filth causing bad air leads to changes in sanitation, in sewage, in water supply. So at the end of the day, even though you don't really understand what's causing the sickness, the solution is still a solution. And so, you might be off on really what role does fetid foul air have in it. But to get rid of the fetid foul air, you have to get rid of piles of excrement on the sidewalks. Well, there you go. It works out. Now, and it's going to be a while to break public health's relationship with this kind of hygienic approach to sanitation, but it's okay. Again, this is where we're kind of in a strange spot with medicine because they're solving problems. Now, from the medical perspective, we're moving towards germ theory, this modern sense of there are microscopic things that cause illness, and these microscopic bacteria, and then later on discovery of viruses. This is going to be the great discovery of Louis Pasteur. And Pasteur is going to be noticing microorganisms in his work in the fermentation of wine. And he's also going to get past the hump of the spontaneous generation of disease. He's able to, this is where he's using, as in the picture you see this, the swan-necked flask that will prevent the contamination of the liquid with any sort of airborne particle, this notion that disease does not appear spontaneously. It has to have something in there. And it's also this idea that you can kill the bacteria or the microorganisms that are present by heating, in the case of milk, to 130 degrees, which is pasteurization. And then expanding on his studies of microorganisms, he's further refining it into vaccines, building on Jenner, who had the smallpox vaccination, who had introduced it in the 18th century. Pasteur, starts looking at, well, can you take weakened or non-viable microorganisms and use those in vaccines? Because in the case of rabies, you don't want to use a live rabies vaccine. At this point, we improve upon it, but the sense that you can take and use these microorganisms to make better vaccines. You don't have to just take, in the case of smallpox, rub, they were using cowpox as their vaccine. But Pasteur lays the groundwork for germ theory, and really takes this off with these microscopic organisms. And Joseph Lister, a Scottish doctor, appropriates this into surgery, because the infection rate and the death from infection rate was very high in surgeries. And so taking care of killing these microscopic organisms, the creation of this modern antiseptic or sterile procedure in surgery. He uses it through chemical prophylaxis, carbolic spray. And then kind of building on the previous 20 years, Robert Koch, a German, he's one that really takes Pasteur's work and runs with it and starts to identify very specific bacteria responsible for diseases. He identifies cholera, anthrax, tuberculosis, and starts working on how to isolate them for vaccine purposes. But also, Koch develops what were called his postulates in the 1890s. In order to say that a particular bacteria causes a disease, these are the requirements. That, it has to be present in every case of the disease. The bacteria has to be isolated from the host, and you have to be able to grow it in a pure culture. These are the rules in terms of you can't just, some very applying specificity to it. The specific disease must be reproduced in a pure culture, and then you also have to be able to reproduce the disease itself. And then once it's reproduced, you have to be able to extract that same bacteria from this new host. And that way, and again, that's how he isolates cholera specifically, and tuberculosis, anthrax. So these these were significant diseases in the 19th century. Anthrax, of course, was sheep and cattle. Not so many people outside off the farms, but cholera and tuberculosis were especially. And that's where we get our modern understanding of germ theory, is kind of at the end of the 19th century. Up until, germ theory, it was still very Hippocratic in understanding this. We were operating on a very classical understanding of disease. So, to reiterate this weird reality, public health and epidemiology, you can prevent a disease without understanding it. It helps to understand it, of course, but once you identify kind of the basics for how it's being transmitted, where it's showing up, who's getting it, and it's capable or possible to prevent it. And then the picture I have here is of the Broad Street pump. Shut down the source, clean up the source, and that's kind of one of those distinctions that you don't have to fully understand the medicine behind it to be able to prevent disease. Now, does that put public health at odds with laboratory medicine? No. They have a very close relationship. They are dependent upon each other. But public health is medicine focused on populations, and medicine is focused on the individual. I mean, one is, the treatment of a population is a very a very different route to take from the treatment of an individual. Controversies that have emerged, and these aren't really controversies; these are points of argument amongst academics. But over the course of the 19th century into the 20th century, life expectancy increases dramatically, and the question has been, why? Why do people suddenly start living longer? Why does the health improve? Is it because we have better medicine? And then the two authors I have here, René Dubois and Thomas McEwen, argue no. It was not a case of having better laboratory medicine, better therapeutics. It was really a case of better public health, and particularly the improvements made to sewage, drainage, and water supply by doing, and also vaccinations. So this notion that it was not necessarily the improvements in medicine itself, but the improvements in, this reform aspect of public health that contributed to the increase in the life expectancy in the West from the 19th into the 20th century. If you'd like to read more about this, and again, these are ideas. There's a lot of debate between this notion, and in some cases it's gross oversimplification. But this sense, René Dubois, The Mirage of Health in 1950, proposes it, and then Thomas McEwen is really kind of the chief architect of this. He wrote The Modern Rise of Population in 1976. This was a culmination of about 30 previous years' worth of work, which is known as the McEwen thesis, that says, the reason why we live longer, better lives is because of public health, not so much because of medical practice. That, like I said, it's a controversial statement, but it's kind of one of those pieces in play in the history of medicine and the history of public health. So something to think about. Now, this has been a little bit longer than I intended it to be, and this has been a very quick overview of the history of public health and medicine in the 19th and 20th centuries. But I wanted you to kind of have some points to think about in terms of how we perceive disease and then what we do about it, and what is the goal of public health? How do we prevent infectious disease in populations? So take some time, digest it, think about it, go back to parts that you might want to, spend some more time with. And if you have questions, just post them under the I've got a comments piece in the channel for this week, and we'll do some more reading from Snow. So thank you very much for enduring this. And again, if you have questions, just let me know.